This is something that I'm going to explain. When do you need the ICU? Okay, which are the reasons to shift the patient to the ICU? Okay, that's the most important thing we're looking at. Okay, so normally the monsoon season starts in, we say, July, August, but the problem starts from somewhere around May. Okay, it starts with hepatitis, probably related to the fact that schools are off, people are eating outside. So hepatitis did not have just monsoon, it increases in monsoon, but it starts from people starting junk food, people starting eating from outside. So it starts somewhere in the month of May and it extends up to December. So dengue peaks somewhere at December. Okay, somewhere in October. So two different things. Malaria and dengue, two different things. So today we will completely finish monsoon illness, and in this aspect I will talk about generally about everything, but leptospirosis I'll feature a little bit more of this. Right, but you must understand that Anopheles mosquitoes is the one that is biting in malaria, and that bites in the evening hours, whereas Aedes aegypti bites in the early morning hours. So the Aedes aegypti is for dengue, Anopheles is for malaria. Okay, both of them are two different things. Okay, normally you will not have malaria and dengue positive. साथ में नहीं आता है. It's very unfortunate if you have malaria in the morning. Morning Aedes ने काट लिया और शाम को Anopheles ने काट लिया. It's very impossible. It's something that is not right. So why am I telling you this? Because very often you have laboratory investigations saying malaria positive, dengue positive. You should understand what is positive and what is negative with respect to the clinical features. Are you understanding what I'm saying? And I'll explain to you in the short while how we demonstrate that. Okay. Now this is very different in different regions of our country. For example, this is Kolkata. In Kolkata, at this time there's actually cholera. Okay. At this time, so this is very close to the Hooghly River. All these green dots are the ones where you have cholera. So it's different region specific. So we are going to talk about Maharashtra. That's why, and when we say Maharashtra, we are also in a triangle called a Tsutsugamushi triangle. Okay, that is we Maharashtrians are in a Tsutsugamushi triangle also, which basically part of the Maharashtra is in Tsutsugamushi triangle, which basically is a disease called as scrub typhus. Scrub typhus. This word comes from the fly called as Oriental Tsutsugamushi. Scrub typhus, rickettsial infections. Okay, as you go northern, if you go and start working at Himachal Pradesh and Madhya Pradesh and all those areas ahead, you will see much more amount of scrub typhus. In fact, among the three diseases that are very common to our country, when you say tropical diseases, is barely scrub typhus is number 2. Scrub typhus is actually number 2. Okay, you are in a country, you are in a state where scrub typhus is not that regular. And remember this, when you think of scrub typhus, that's why the history taking becomes very important. In history, what are you going to ask? In history, did you go for trekking? That's the most important history. You really go for trekking, wilderness. You have to be exposed to wilderness to get scrub typhus because you have to be bitten by a certain bug, by a bug. Okay, the bug is a tick-borne disease, so you have to be bitten by one of these bugs. These bugs are not there in the later part, early part of the week or year and later part. It is somewhere in the somewhere in August, September, October that these bugs are seen more. These ticks basically, they are seen more at that time. Okay, so classically scrub typhus comes, and this is one of the diseases in which tropical disease, one of the diseases in which skin manifestations is something you have to look at, and this is sine qua non. When you look at an eschar means a small black color thing that is there on the body. That is sine qua non for scrub typhus. So when you look at it, it is a diagnosis. In tropical diseases, few diagnoses are there which are skin related, which you can find out directly by looking at the skin. One is scrub typhus, the other is dengue. It's the same thing. Dengue, what do you see in dengue?
Rashes.
You can see rashes, you can see, where rashes? You can see petechial rashes. You can see petechial rashes. Where do you see them?
Abdomen.
You see it usually in the extremities. You see the extremities. That's why when you actually inflate the cuff, you see rashes in this area. Okay, rashes. Okay, petechial rashes. You can also have maculopapular rashes in those cases. Then which other disease you can diagnose? By rashes? By skin manifestation. Typhoid. We say rose papular rash.
Rose spots. Rose spots chest.
So rose papular rash you must understand, because typhoid is something you may have in rainy season. It's one of the tropical diseases. When you say tropical, you don't think just malaria, leopard, and dengue. Anything that happens in the tropical disease, including H1N1, would actually be something that what happens in a tropical in a patient is when it's raining, everybody is huddled inside a room. They're not roaming around. In summer season, people are roaming around here, there, everywhere, going around. But what happens in a rainy season? Mostly people stay at home. So the chances of actually spreading respiratory borne diseases also becomes very high. Okay, so H1N1 is something that comes in over here. But importantly, what happens with scrub typhus? In scrub typhus, what happens in scrub typhus? At the moment, the case fatality of scrub typhus is very low. Why is it very low? Why is it very low? Because everyone at the drop of the hat puts doxycycline. which is one of the drug for choice, doxycycline, azithromycin. And why you must remember scrub typhus very well is because of the fact that we had a very beautiful study that came out a year ago. Okay, beautiful study. J.V. Varghese. J.M. Varghese is a doctor from down south, CMC Vellore. I think CMC Vellore, if I'm not mistaken. But he's a Malayali, and they had a huge they had a huge trial called Interest trial. Interest trial is a trial that was done by India. Okay, a trial done by India, one of the few trials done by India, because you must understand, even though we talk tropical disease, and India is part of the tropics, we still don't have any guidelines that come out from malaria, from lepto or dengue, from randomized control trials from our country, because the investigations are not as much compared to other. Okay, you understand what I'm saying? It's not, we are not doing super randomized control trials. So this is one of the investigations that you must understand. It says that a combination of doxycycline and azithromycin is better than doxy or azi on its own. So I just said everyone gets doxy, everyone gets azi, but if you give a combination of doxy and azi, it actually works much better than this for scrub typhus. Clear? Scrub typhus. Now coming back to Maharashtra. Okay, this is the census of India. Okay, India. What happens in India with respect to dengue? If you see, the green part is where dengue is. So it's really not there in this part of the world. It's not there. When you look at Bihar and all, it's Kala Azar and all. You know, you look at things like that. When you look at Bihar and that area and all, you know, you look at other diseases. You don't look at dengue. Okay, you don't look at dengue. Now, what happens in Maharashtra? This is in 2018. Okay. Oh, I didn't put the today's. I didn't put a big on this. Actually, there is data from now also. I will put it. Okay. So the data for now in 2023 was 15,000 cases, and till 2 weeks ago, it was 3,000. Till 2 weeks ago in our country, in Maharashtra, it was 3,000. Right? It was hardly there, not a single death. In 2023, we had almost 55 deaths. Okay. Whereas here we didn't have a single death till now. Till now, we don't have a single death. This is another PowerPoint, Mera. Actually, here other 55 deaths. 55. Yeah, 55 deaths were there, and there was not a single death till May 24th. There was not a single death till May 24th this month. It was not there. Okay, this month not there. What I have put over here is a difference in 2018 and 2022. So what it is basically saying that the malaria incidence is actually coming down. The malaria incidence is actually coming down. Malaria incidence is coming down. This is what we have seen. Malaria incidence is actually coming down. In fact, case fatality rate also is coming down. Deaths are coming down. Why is that so? Because the availability of very good anti-malarials. The moment a person comes in, anti-malarial is given, so that's why immediate treatment occurs. So the malaria deaths are actually coming down very clearly. Okay. Now, if you look at Maharashtra, 8,806, no death till June. In May, there was till May there has been no deaths. May 2024, there have been no deaths till May 2024. Okay. Basically, again we are talking about the fact that there has been changes in the frequency. Now, what has been the trend in Mumbai? Okay. So what happens in Mumbai? Let me explain to this in Mumbai. Okay, the last 2 weeks, 2 weeks to 15 days. In the last 15 days, there has been a sudden spurt of cases, and 600 cases have been recorded. Around 600 cases have been recorded in the last 15 days. Around 600 cases, of which malaria has been the highest, dengue has been slightly lower, and H1N1 is coming. Okay, so you have 3 diseases that are coming in. There are 57 cases of H1N1 that has been reported. There has been a good number of cases of malaria that has been recorded in those 600, and there have been cases of dengue that have been recorded. So malaria has become slightly higher. Okay, so first question is, what is sepsis? Sepsis is dysregulated immune response. Sepsis is dysregulated immune response to any kind of infection. You know, when I say infection, it doesn't mean bacteria, it doesn't mean virus, it means so many other things. It means malaria also. You understand? Infection with a bug is an infection after all. Okay, infection by anopheles or parasite is an infection after all. So whenever you have an infection, there is going to be a dysregulated immune system, and it depends on how much dysregulated you are that you become septic or not. Sepsis is basically dysregulation. Inflammation and anti-inflammation working together. Okay, this is what is basically occurring. Initially we thought it was simple, but it is actually very complex. Our immune response is very well balanced. Today you have fever, your immune response balances you very well. You don't go bad, you don't go to the ICU. You don't even get admitted. As of now, immune response is so good that you have fever, you are sitting आराम से बैठे हो, problem नहीं हो रहा है, you are taking a paracetamol, getting better. You are not getting bad. Okay, so that is a small difference between sepsis and all these things. What is sepsis? Sepsis becomes the whole immunity gets dysregulated, completely dysregulated. Okay, dysregulated sepsis immunity. That's a dysregulated reaction. That means what is happening over here? That you get sepsis. Okay, and instead of actually you getting better, your acute phase response coming down, you getting better, you are actually getting worse. That is what is dysregulation occurring. Initially we thought that we had an anti-inflammatory reaction and a counter anti-inflammatory response. We thought that, but what we know now is that it works together. And remember this, there's something called epigenetics of sepsis, which basically says that each individual is different. Okay, the same disease for two individuals will be very, very different. Okay, that is because age, it depends on age, it depends on comorbidities, it depends upon environmental factors, it depends upon your gut microbiome, how good it is. It also has epigenetic modifications that we have in these cases and polymorphisms of your genes. So what happens is, today if Sari gets a bite of a mosquito, you get a bite of a mosquito, maybe you develop the infection of malaria, making you having fever, chills and all this nonsense that happens, and you will probably just have one fever and you're fine. So it all depends on what your genetic polymorphism is all about. So this makes it even more difficult for you to understand which patients you should get to the hospital, which you shouldn't. It makes it very difficult. But underlying point is what? If you get into sepsis, it is dangerous. Underlying point is that if you get into sepsis, it is very, very dangerous. Okay, that's what basically occurs because it's dysregulated completely. So why am I talking about sepsis? Because of the fact that all the tropical illnesses can lead you to sepsis. Let it be Japanese encephalitis, let it be West Nile fever, let it be malaria, let it be leptospirosis, let it be dengue, let it be any of the tropical diseases, you can have sepsis. And that is a problem with the sepsis definition. The sepsis definition does not include what to do with malaria. When you say sepsis and you talk about sepsis, you say 1 घंटे के अंदर we have to give the antibiotic. If it is possible, probable sepsis, in 3 hours time you have to send blood cultures and try to give the antibiotics. It's not about antibiotic. It also talks about antifungal. It talks about blastomycosis and histoplasmosis in sepsis definitions. But it doesn't talk about this because this entire thing of sepsis, is done by Society of Critical Care Medicine, Surviving Sepsis Campaign Guidelines in the United States. You understand? The whole thing is done in the United States. So, in couple of private tertiary care centers, SSCM has come up from. It has not come up from India. Surviving Sepsis Campaign Guidelines. All of you should know this pin pad. Surviving Sepsis Campaign Guidelines. It's very important that you know Surviving Sepsis. If you don't read it 5 times. Before exam parts, 5 to 6 times you should be reading SCCG 2021. Okay, this SCCG is a guideline that will be asked in every exam. Okay, it is a guideline that tells you how to manage sepsis, how to treat sepsis, what is the definition of sepsis, what is the definition of septic shock. Okay, unfortunately these guidelines come from United States. Okay, and in the United States, malaria, lepto, dengue, all these things are very, very low. So they have not even put it in the guideline. So it is a big policy of that sepsis definition. So when we talk about malaria, we should think of sepsis. That's what I'm trying to tell you. It is sepsis. In our country, malaria, leptospira and dengue all come as sepsis. Okay, sepsis. So that's what sepsis is all about. That's why everything has just one thing. Sepsis. You want to say everything is just one thing? Sepsis. Alright. Now let's take the example. Okay, you have this lady who's a 36-year-old lady with fever with chills. She has a cough with a tinge of blood-stained sputum. Okay, respiratory is 24 since last 2 days. Oxygen at 4 liters per minute and SpO2 95. Otherwise, okay. She comes with a casualty like this. Where will this patient go? Should this patient go to the ward or should this patient go to the ICU? What do you feel it should go?
ICU.
Why ICU?
Because blood-stained sputum.
That's okay. So if I cough excessively, I'll have blood-stained sputum.
Oxygen requirement is there.
So that can be managed in the wards. Wards, we have oxygen. I mean, both can be done in the wards. Don't you agree to this? Oxygen can be done in the wards. Have blood-thin sputum can come. You excessively cough today, you'll have a blood-thin sputum in some time.
Respiratory rates.
Okay, so this fever with chills is there for 2 days. Okay, she had 2 days of fever with chills. She comes to the casualty, and now in the casualty, you see this patient. They call you from the ward saying, they call you from the casualty saying, "Take one patient, aake dekh lo." Abhi you have to go and see the patient.
Yeah.
Okay, you see this now what?
So its rate is on higher side. If we do CBC, platelets is on lower side. The risk of intra-alveolar.
So platelets are say I'm giving you 80,000.
But still it is on the lower side.
It's 80,000. It's 80,000. I'll make it for you 1,20,000 now. What will you do? What characteristic in this will tell you something important?
X-ray करके.
So there are you talked about. Is the age important here?
Yeah.
Why?
More immunogenic reaction will be more.
Is fever with chills? वैसे coming to fever with chills, can you actually figure out with fever with chills what is the disease you have?
Lepto, dengue, malaria.
Say you have a patient come with fever with chills. What is the things you're going to look at? what in say a patient in this particular now this environment, people who have person come with fever with chills. What are the various diseases on your finger you can talk about?
Dengue, malaria.
Dengue, malaria. Then what about the fever is important for you? What about the fever? What are you talking about?
Variation.
No. What are the variations?
Alternate day.
So there is quotidian. There is
Tertian.
So these kind of diseases in theory is very good. In theory, quotidian malaria is falciparum, tertian malaria is malaria, is P malaria. In theories, it never occurs like that. It never occurs like that. Step ladder pattern and typhoid. These are the various kinds of things that we talk about in theory. It normally doesn't occur that way. It normally you have just fever. But once you have fever with chills, you will ask these questions how long the fever has been. Why? Because in dengue fever, you know the problems will start after the fever has gone. After the fever has gone. Okay, the fever was there 2 days ago, it's not there now, I'm not having any fever. Now is the time when the problem is coming, he's having vomiting, he's having this, he's having that, this will come here. Yes, so the fever is a very important thing, very important thing. Okay, fever. Alright. But that doesn't mean he goes to the ICU or ward for that. So the important thing over here, according to me, is this. Okay, the RR being 24 with mild degree of breathlessness. Okay, this is the real important thing. Mild degree of breathlessness along with an RR that is 24. And why is that so important? Why do you feel that is so important? Let me just explain to you. Let's take the condition of a fast respiratory rate. Okay, if you have fast respiratory rate, the next thing you're going to do is because of what? Because you have injured lungs. Others RR can't go fast. You know, you're looking at a respiratory rate. Malaria and respiratory they are not together. Malaria is a disease where you have fever, but the RR going fast without that fever at this moment, and RR is fast, patient is there, fever is not there, but RR is fast. Okay, what is going to happen in this case? There is an injured lung. There's an injured lung. This is because patient has got a high respiratory drive because of the injured lung. Whenever you have an injured lung, you will have a high respiratory drive. Now what does that cause? That causes strong inspiratory efforts. Patient it's a stronger inspiratory effort. What you are all sitting here sitting normally, if you keep sighing all the time, what will it cause? It will cause over distension. It will cause pendulum mechanism. It will cause atelectatic trauma. It will increase your vascular transmural pressure, and this per se will aggravate the pre-existing lesions, and this problem will keep on exacerbating. Okay, this problem will keep on exacerbating. This is what is going to happen. He will go back into this injured lung, and more injured lung, and more injured lung, and more injured lung. Okay, so you must be very careful in such patients who come with a high RR. Not only that, if you have a high RR because of the injured lungs, there is a volume loss. There is some kind of ARDS developing, there is some kind of pneumonia developing, volume loss is occurring. Smaller tidal volumes they start developing and a high respiratory rate, which will again cause increased shear injuries because it's collapsing, opening, collapsing, opening, collapsing, opening. There are some alveoli that are open, some that are closed. The shear between them pressure is so much that it rubs and causes problem. So shear injuries will occur. This shear injury will cause more injured lungs. It aggravates the pre-existing. Again, the same thing starts out. So maybe if someone calls you from home and tells me this is what it is, you count the RR. Count the RR. RR is bad? No. You come to the hospital for certain. Then when she comes to the hospital, look at the degree of breathlessness. As a doctor, you're going to do that. You're going to auscultate. You're going to figure out what's happening. You find a problem. No, this patient probably needs the ICU. You understand? Because if it goes down, patient goes down very tremendously. You understand? So does this patient require the ICU?
Yes.
Yeah, most probably this patient does require the ICU. Can he be at home? No. This person can't be at home. Clear? This person can't be at home. Now let's take this. Ashok, diagnosed as dengue, felt very weak. He felt very weak. This is very often they call you. Okay, blood pressure is 90. Turn on IV fluid so that he gets better. Where this patient can be managed? Ward, ICU, home. Ward, ICU, home. If ICU, why ICU?
Dengue में याद है fluid loss, volume loss.
So every patient come to dengue.
Shock syndrome.
Will every patient come to the ICU? This patient is in front of you. See, all your dengue shock syndrome are very good. It's right, but that is in theoretical discussion. We are in a practical scenario now. We are in a scenario where the patient is in front of you, and this is what you are saying. You have seen the patient as a casualty, and you decide, okay, you are the decision maker here. Very often, you will be the decision maker. You know, as you grow up, when you say 10 years from now, you may be admitting patients. You know, you will get a phone call saying this is what it is. What are you going to do? What do you think you are going to do, Vinod?
What can be managed unless and until platelet is very down.
So your metric is platelet.
Platelet BP also if 90, can we manage with fluid then?
Can we manage with fluid? So he says his metric is BP and okay. See what happens is you are all working in ICU. So for it's a simple हो गया फिर. You understand? You are working in ICU तो तुमने वो दूसरा साइड वाला स्टोरी देखा ही नहीं है कि क्या हो रहा है वो साइड में. हाँ, that's why you all feel अरे this can be तो क्या है? Simple है ये. हाँ, ऐसा लग रहा है तुम लोगों को. But let me explain to you why this is very important for you. All right. The answer over here is this. Now, what you must understand is if the mean arterial pressure, that's what I'm going to look at, mean arterial pressure. If the mean arterial pressure is less than 55, what you're seeing over here is acute kidney injury, what you're seeing over here is acute myocardial injury. This is the time, in minutes. Time in minutes. Every time there is an increase in the time that the patient is below mean arterial pressure 55, there is an increased incidence of acute kidney injury. There is an increased incidence of myocardial injury. Are you understanding? So a map of less than 55, which is this blue line here, has got an exponential rise of acute kidney injury in minutes. And how many minutes? In fact, even smallest amount of minutes, even the smallest amount of minutes will cause this. Look at this. This is the minutes. 0 minute, 1 to 5 minutes, 6 to 10 minutes, 11 to 20 minutes. Even when you go to 11 to 20 minutes, the risk adjusted odds ratio for getting acute kidney injury is quite high. It's quite high for myocardial injury. You understand? It's quite high. So there are problems that are going to occur with these patients whose mean arterial pressure are on the lower side. So our patient's BPO is 90, which is definitely map of less than 55. Okay, you probably have a map of less than 55. So you said, I'll just give some fluids, isn't it? This is exactly what you said. So even the National Vector-Borne Disease Guidelines says the same thing. It says what? Give fluids. This is an active vector-borne. If you open up vector-borne diseases, we have got a national guideline for every disease. Okay, you can very well go and refer to that, but you must remember that is for the whole of India, not for places like a tertiary care center where we can do a lot of things. Okay, that's for the whole of India where there are community health centers, rural centers, and things like that. Okay, so you have what it says, the simple thing that it says, follow the hematocrit, follow the water. Give them water, give them fluid. This is what you would do in a periphery. Yes. In a periphery, a person comes, you give fluid here, give fluid, let them become fine, look at the hematocrit. But we are not those people who are in the periphery. We can do something better than that. We can do something better than that. And why it's important for us to do better than that? You might say, okay, just give some fluids. This is what he exactly said. I'll put him in the ward and give some fluids. Okay, but what you must understand is 2.3% have an increase in mortality per liter of excess fluid given in dengue fever. If you decide to give fluid and you give any amount of water fluid, even 1 liter excess of fluid, even 1 liter of excess of fluid will increase the mortality to 2.3% increases mortality, death. 100 out of 2.3 out of 100 will die. If you give excess fluid. So the big question is how do we do this? And the second thing is only 50% are fluid responsive. Any given moment when you are in sepsis, only 50% are fluid responsive. 2 people sitting over here, I give fluid in sepsis to you, give fluid in sepsis to you. You will respond by an increase in cardiac output by more than 10%. You will not do that. Only 50% are responsive to a fluid when they are in sepsis, and sepsis is what we are talking about. Not otherwise. If you are sitting here, there is no problem. Okay, there is a 50% of them are undergoing fluid responsiveness. And importantly, what is also important, you give fluid in 1 hour, your BP will go down. It's just that 1 hour. In 1 hour, your BP will come down. Have you seen this very often, right? In the ICU, you see this. You give fluid. Why do you think fluid increases blood pressure? Sorry.
Intravascular compartment.
So how much is your intravascular compartment? It's 60% of your body weight, right? So we liters in 50 liters, 47 liters, very high amount will be there, right? Blood volume is only very high. उसमें तुम 1 लीटर देखिए क्या करने वाले? उसमें होता है 1 लीटर going to do. In fact, all that you might do is you might drop the blood pressure because your bradycardia will, your reflexes will kick in. You're giving fluid so fast, your carotid receptor तुम्हारा stimulate हो जाएगा और उसको लगेगा ज़्यादा BP आ रहा है, relax हो जाएगा. It will become vasodilated. You understand what I'm saying? Because you're giving fluid so fast, your receptors will get stimulated. So how normally the fluid challenge actually improves is usually what happens is that there is also a coldness factor. It is cold also, so that it causes vasoconstriction. It causes liberal fluid to a little hypothermia occurs. That's why in some time when everything approximates an hour later, fluid moves out of the system, there's nothing over there and patient becomes dilated and again the BP drops. So our patient who was here, if you gave some fluids, either he's going to be 50% responsive or he's going to leak out into the system within an hour, and if you have given that excess amount of fluid which has leaked out into the system, he is going to die. 2.3% chances he is going to die. So that's why such patients whose mean arterial pressures are not okay, you will drown them in the fluid. You will actually drown them in the fluid, and that's why you need to find out fluid responsiveness. And the only way you can do that is by a lot of things that we do in the ICU. We do stroke volume guided fluid resuscitation. We do tidal volume challenges if they are intubated. If we do EPCO2 challenges, we do a Vexus scoring to understand what fluid is going on. We look at IVC collapsibility and also looking at the limits of fluid transfusion that we have. We do profiling of these patients to understand whether they are fluid responsive or unresponsive, and we carefully do these fluid challenges. Can you do this carefully guided fluid challenges and all of these in the wards? You can't. So, what do you feel this patient can be managed in the wards now? Less likely. Less likely. I don't want to take any risk in my patients to probably manage this patient in the wards, in the ICU. Right, this can be done only in the ICU. There's no doubt about this. Now so Ashok has to be managed in the ICU. There is no doubt about it. Ashok needs to manage the ICU. Now there are certain patients that will require a different set of management, and you must understand when you're dealing with patients that are there in the hospital. Okay, for example, the patients of diabetes or pregnancy. So if you have a patient of pregnancy coming to you, all the signs and symptoms that you have in tropical diseases are masked. All the signs and symptoms. We talked about blood pressure, we talked about respiratory, we talked about pulse rate. Everything is masked, especially when they are near term. Okay, everything is masked. They have progesterone. It's a very different situation. Everything is changed. Everything is changed in such conditions. So you can't look at pulse rate and say, ठीक है, pulse rate अच्छा है, या PSI 100 है, हाँ, या BP तुम्हारा BP 100 average को ऐसे बढ़ा दो. Very difficult to understand. Because why? Because physically they have hyperemesis. So the early warning symptom that you have with respect to tropical diseases, of which dengue, the early warning system is intractable vomiting. The intractable vomiting will be seen in pregnancy. Very high possibility. You will not be able to differentiate whether it's dengue or it is actually hyperemesis coming from the pregnancy. You understand? You have increased heart rate. They normally have 100, 110. They normally have 100, 110. That's their heart rate. That's their regular heart rate. So at that time, looking at this, you cannot decide what to do. So you should understand clinically कि ये क्या चल रहा है. 100, 110 है. Do I need to put this patient in the ICU or not? You must clinically try to understand this. They already have low BP because of progesterone. The BPs are hundreds, 90s and hundreds. So you will not know only whether this is related to dengue or malaria or salmonella or things like that. You will never know only what it is. Okay, all right. They have a plasma leakage which is very difficult to judge because normal tests have become very difficult. Ultrasound, auscultation, everything becomes difficult. You can't hear half the things, isn't it? You can't understand. You got fluid overload everywhere, anytime. कभी भी देखो, they are obese. They have a lot of fluid here and there, here and there. Very difficult to judge. If pair में ऐसे because history is being there, because the uterus being there and edematous, you will not able to judge leakage. Otherwise, when you say dengue fever, you say plasma leakage, right? We can't judge that. So pregnant patients are having a different set of situation where they may require inevitable delivery. So don't let the patient be at home for some time. Second, they need ready blood and blood products because these patients may suddenly have platelets that are low. So in these patients now, if they're in the ward, don't say blood grouping cross match में बाद में करूँगा, करके रखो. If they're in the ward, if they're in the ICU, करके रखो. Because last moment इनको blood अगर जरूरत है तो बहुत ज़्यादा जरूरत रहता है इनको. So ready blood and blood products have to be available. Trauma has to be minimized as much as possible, and newborn needs to be monitored. Such patients, newborn needs to be monitored, and that is the reason that you can't do this in a home. You may have to keep it in the wards, and when you're looking at it in the wards, you have to be very careful with the signs and symptoms that we have with respect to this disease. Clear? Other thing is diabetes. Now diabetes is a very difficult disease in the first place. The urine output going up and going down, you will not understand because it might be decay. It might be just decay. You'll never figure out. Decay comes in immediately even with any infection. With any sepsis, decay can come in. Decay can come in. So malaria can cause decay. Dengue can cause decay. You don't know whether it's malaria and decay, what is happening. If the urine output is coming well, that may be decay. It is renal injury occurring, but there may be decay. You understand? So diabetic ketosis can come in. So they develop a hyperglycemic, hyperosmolar state very, very quickly. These diabetic patients when they are. So you have a patient in sepsis coming to you, that is malarial sepsis, and the patient is admitted to the ICU, is diabetic. You should be ready, boss. This can occur anytime. Okay. Second thing is dengue shock can be diagnosed as DKA. Okay. The other way around can happen. Okay. The dengue shock can be diagnosed as DKA. Worsening of intravascular hypovolemia occurs very, very quickly in such cases. Very quickly. Okay. They have increased chances of bacterial infection, and OHs that they are giving that doesn't get absorbed because everything is edematous. Nothing is getting absorbed, so their sugars might go up. You'll not know only. That's why such patients should be very careful. You should be careful with such patients. Metformin itself will cause lactic acidosis. You'll not realize that it is lactic acidosis coming from metformin. You'll not realize. So there are a lot of confounders that come in when it comes to diabetic patients. So that's why tropical diseases in diabetic patients you should be very, very careful. Very, very careful. Right? And the other thing is about hypertension patients. Now, hypertension patients, again the same problem. Patient is on a beta blocker. You will not know whether why the patient is bradycardic. You will think that it is because of the beta blocker. It might be sepsis from typhoid, which is causing the bradycardia. Are you understanding? Huh? Other way around, they may not have the blood pressure. Their blood pressure may be 110. You might think that is normal. It may not be normal because his usual blood pressure may be 150, 160, 170. He is getting 3 antihypertensive agents. And it's 110 over here. That is actually shock. Relatively, it is shock. If it's at 130 and he was on 3 antihypertensive agents, relatively the patient is in shock. So you have to understand, boss, this is 130, 140 is usual pressure. You ask, what is usual pressure? It's important for you to understand this. Okay, and then you find out that this is kind of shock. So that's another confounder. Okay, their high creatinine may be actually normal creatinine. That might be their usual creatinine. Because they are hypertensive patients, diabetic patients. So you should be able to understand what was their baseline. Baseline creatinine is very, very important in such cases. Right? And also those patients who have CKD, because it's a direct relationship to mortality. Patients who have CKD and tropical diseases have direct relation to mortality. And when you have CKD, you give fluid, it should be whether it is leaking out or not, or because of renal failure, you never know. So you have to be very, very careful. That's why when you're working in ICU now, you are in a very good situation because you are here, you are in the front in ICU, you have ultrasound, you have this, you learn off quickly how to differentiate problems. And this I cannot teach you. You will have to learn it by the way we are doing it on a daily basis. As time goes, you have to learn why is it like this, why is it occurring. That will come only when you keep on investigating, keep on thinking, keeping on looking at the ultrasounds, keeping on doing your examination, daily examination. You will come to that conclusion as to what that's occurring. Okay, and to make matters worse, they have poor fluid tolerance. They may already have increased bleeding chances, increased risk for acidosis and dyselectrolemia. Urine output cannot be used as a guide at all here, and limited effect of a tablet. Okay, so they have all these problems that come in renal failure. That's why such patients, as far as possible, the threshold to shift to the ICU should be low. You should quickly shift the patients into the hospital or into the intensive care unit. Okay, so these are those patients that are problematic. Usually, these are the various reasons why you would actually get these patients into the hospital. Okay, there are early warning signs that come in. So, if the patient has got a platelet count, for example, a person calls you and says platelet count is 120. What do you do the next thing? You tell them wait for 72 hours. If the platelet count is dropping further, please get admitted. More than 30% drop, अगर हो गया है, 20% drop हो गया है, get him to the hospital. Okay, if the patient calls up and says, my platelets are 120, what do? No, you watch yourself for vomiting, watch yourself for encephalopathy, tell somebody to keep a watch on you whether you're getting, whether urine output is coming down, look at your urine color, okay, and then look for excess amount of rashes. All these would indicate that you come to the hospital. Okay, in the laboratory, a few things that you will look at is the platelet count, is the hematocrit, and is the SGOT, SGPT. Okay, if that goes more than 3 times normal, that patient requires hospital. They are the early warning signs. Okay, initially we used to differentiate this into undifferentiated fever, dengue fever, dengue hemorrhagic shock, dengue shock syndrome. It's not like this now. It's either dengue with dengue early warning signs and dengue with dengue shock syndrome. It's completely divided into 2 parts. Okay, 2 or 3 parts maximum. Especially those patients who call up who are living alone, who don't have anyone there. In a tropical disease, there's no bus. You come to the hospital. He's alone, father, mother, very old person, people at home. No. Come to the hospital. If you're old, come to the hospital. We have a cure. If you are one of the people in malaria, you have a cure. Come to the hospital. You understand? There's something there that's there. It's not cancer. Right? Now, can we predict this? So, this is a system, this is something that came from Bhubaneswar, very nice study, which actually said, this is there or where is it? Okay, so it's like this. So, if you have anemia, there's 1 point. If there's acute renal failure, there's 2 points. If there's respiratory distress, there's 3 points. And if there is cerebral malaria, it's 4 points. You add these points up. Once you go more than 2, 3 to 4, you admit this patient, whatever happens. That means if you have any one of this, any 2 of this, you are inside the ICU. You are inside the ICU. Clear? If you have any 2 of this, you are inside the ICU. So 3 organs: brain, respiratory system, and kidney. If any of these occur in a healthy individual, okay, along with anemia, that patient will have to be in the ICU. Okay, because the mortality is more than 10%. Okay, so then another study also, too many things in that study which actually says doing this. But if I put this all together, it's something like this: if there's a decline in platelets of more than 72 hours, AST is going significantly higher, that is more than 3 times normal. You have abdominal pain, vomiting, liver enlargement, and you have altered serum hyaluronate levels in the hospital. So these things, if you have any one of these things, you move the patient to the ICU.
We have 11 flow. 11
Persistent vomiting. for
Persistent
last 4
vomiting.
days.
So that fits completely
Yeah.
into this. So that patient should have been in the ICU long ago.
Yeah, she came after 4.
Yeah.
And she came to the emergency 2 days back.
Hmm.
They gave her fluid and sent her back. Then she came back again with
See,
the vomiting.
answer your question now.
Yeah.
So you just put these things in your mind, and you probably would have transferred that patient yesterday. I went and saw the patient in the ward,
And then you
I should just transfer the patient immediately.
Hmm.
I said okay. It's very important for us to understand these small points. Okay, small point, but important point. That lady suffered for the last 4 days because she was not shifted to the hospital. Was she was not shifted to the ICU, and then suffered, and then came to the ICU. You understanding? So these points are very important. We miss these points. It's very important. We miss these points. We should not miss these points. It's very important. Okay, clear on this? Okay. Now this is very important. Okay. अपना शिखंडे ने किया ये डॉक्टर शिखंडे. I think it was his thesis in KM hospital. So what they did was they looked at the whole percentage of monsoon illnesses versus those with monsoon tropical illnesses. Kidney injury in all the other illnesses versus monsoon illnesses. So all other illnesses, the kidney injury was somewhere around 2.3%. But when it came to monsoon illnesses, it was 13.2%. So if you put every sepsis together, bacterial sepsis together, and you put tropical diseases together, those that come with tropical disease and monsoons, their acute kidney injury rate is higher. Whereas those that are coming with just sepsis, their acute kidney injury rate is not that high. Are you understanding? So, and when they studied everything, what did they find? They found out that these were the various diseases that they looked at, which I just want to talk to you about. Leptospirosis, hepatitis C, malaria, dengue. These are the diseases that they looked at in monsoons. They found the highest incidence with leptospirosis. Can you see 66.7% with stage 3 acute kidney injury? Okay, 66.7% followed by malaria, and then comes dengue fever. So you would have thought it's the other way around. You all would have thought that maybe it's dengue that will first cause renal failure, but it's not like that. It is leptospirosis that is responsible for causing these hospital admissions at a bigger rate in our city, which causes acute kidney injury, at least by the study that we have over here. Alright, and when they looked at why this was occurring, why leptospirosis, why malaria, why dengue, why are they causing more than you have these antibiotic sepsis and all this. When a patient comes with bacterial sepsis, first thing antibiotic goes, very quickly patient comes in. Bacterial sepsis, immediately you start treating, those patients get better because there are guidelines that says give fluid, give doses, do that, keep doing all these things, patient does better. But what happens in our countries, they found all these things over here. These are the various reasons as to why the prognostic factors they tried to figure out, and they found out the most important prognostic factor was actually this: delay in the initiation of treatment. That's why we're doing this lecture here, to understand why you should come to the hospital quickly. There's a delay in the initiation of treatment is a primary cause for acute kidney injuries, what it appears in most of these illnesses. Let's take this.
According to that study, lepto causes highest chances of failure, but usually lepto is common in Mumbai.
In Mumbai.
If you consider whole Maharashtra country.
No, it's not. So if you go to the belt, Kolhapur belt, it is chikungunya.
So फिर तो उसका incidence change होगा ना सब.
100%. This is what I'm talking Mumbai.
KU hospital.
But on the whole, no, if leptospirosis you get, first of all, you don't get leptospirosis all over. Leptospirosis is a disease. Which states have leptospirosis? Which states have leptospirosis?
Coastal areas.
No. The Kerala has it highest. Kerala is not poor socio-economic centers. The highest amount of leptospirosis is where? Kerala. It is seen in Kerala. Okay, Kerala is got the highest. Then comes Maharashtra. It's like that. It's the more of the southern districts that you're seeing leptospirosis. You don't see it in the entire Maharashtra. You don't see it in the Deccan climate. It's not there at all. So how do you diagnose leptospirosis? What is leptospirosis? It's caused because of
stagnant water.
It's caused because of what?
Urine of now mouse and animal urine.
It is caused because of what?
Animal urine.
What is the organism? Leptospira interorgans. Okay. This one. Okay. So what is it caused by?
Leptospira interorgans.
Yeah. Leptospira interorgans. Okay. These are ectohemorrhagica and interorgans. So this is spirocheta. This is spirocheta that actually enters into the break of the skin when you wade in a water. Okay, so how do you diagnose leptospirosis? What are the classical manifestations?
Fever with chills.
So it is very non-specific. Everything is non-specific. When it comes to malaria, when it comes to dengue, when it comes to leptospirosis, you can have the same symptoms all across. Everything will be there. Fever, body ache, not feeling well, jaundice, respiratory distress, urine output going down, history, everything would be there. Everything would be there. It is absolutely the same. That is why as a doctor in the intensive care unit or doctor at treating such diseases, you should be able to pick up what is what disease is what. You understand? So how do you pick up this? How do you pick up leptospirosis? For example, let's take the example of our patient has come into on the other side. The young girl is coming over there. Okay, the young girl is coming over there. She has a history of whatever history it is. What do you call her? What do you call lepto, malaria, dengue? Why? So for diagnosis,
Maybe lepto.
Why maybe
because
lepto?
She has history कि मतलब उसके घर पे पानी आता था.
Dirty water,
Dirty water.
So how do you diagnose this? So it's not so simple. Okay, so when you want to diagnose leptospirosis, it's not just कि पानी आ गया तो मेरे को leptospirosis हो गया, मैं water park में गया मेरे को leptospirosis हो गया, ऐसा नहीं होता है. It doesn't work like that. Okay, that is the reason initially before even government came up with guidelines, the test of choice was what? Is the gold standard?
PCR.
No.
नहीं, हाँ.
No, that is very delayed. What is the actual test that the recommended test is something called as MAT. अनंत नारायण में पढ़ा रहेगा. अनंत नारायण book क्या है? So I used to hate that book. But ठीक है. But MAT was the first thing that you talk about. That is microscopic agglutination testing. Microscopic agglutination testing. This is the gold standard. This is what was recommended. अभी मुझे बता लेप्टोस्पायरा ऐसे जगह पे हो रहा है जहाँ पर जरा टाइम लेबोरेटरी का टाइम नहीं है. Very difficult ना. Very difficult to actually do microscopic. Microscopic agglutination test is not done only anywhere. It is not done. It's a very cumbersome procedure, difficult to do. Very difficult to do microscopic agglutination testing. So what happens is we have to follow a certain criteria. Does anybody know the criteria here for leptospira? Anybody? Leptospira. Diagnosis leptospira. All of you are working in ICU. You all should be knowing the criteria. You all have to be knowing the criteria because it doesn't work otherwise. You should all know, irrespective of whether you're intensive care students or not. All of us should know. But intensive care students should know this. It's a clear fail. So the criteria is what? Modified Fair's criteria. You should have this criteria called as modified Fair's criteria. Modified Fair's criteria, which is divided into three parts. It is divided into three parts, which are clinical, okay, epidemiological, and testing wise. You should have three parts to the entire criteria: clinical, epidemiological, and testing. Okay, and these are all assumed given points. Okay, for example, here when you have headache, okay, fever, jaundice, meningism, conjunctival suffusion. These are the usual manifestations that you have with leptospirosis. Okay, so each of these points are given points. Each of the given points, 2, 2, 4, 4. These are the points that are given to these. Okay, there are points assigned to these ones. But there are only 2 and 2 and 2, and the combination of meningism. Meningism means neck rigidity, headache, altered mental status, and photophobia. Meningism. When you have this combination, you have 10 points here. Okay, you have 10 points here, right? The rest are 2, 2, 2, and 4. Okay, the rest are 2, 2, 2, and 4. So 2, 2 points. So that means to say most of our patients will be only will be somewhere around 4 points or 6 points. 4 points or 6 points there will be no fever, neck stiffness. You may not get meningism at all. You may just have fever and jaundice. You may just have fever or something like that. So it will be 2, 4 points. 4, 5, 6 points hoga maximum. Barabar. But you have to add the epidemiology into this. The epidemiology actually involves you to actually wade in raining water. Wade in rainwater. Wade in rainwater. So that comes as 15 points. Wade in rainwater. That means you're wading in rainwater. That is 15 points. So epidemiologically it becomes very close when you look at wading in rainwater. Then come the recreational sports, which is around 10 or something like that, where you are in water park, things like that. water park, there comes the recreational sports. Okay, then comes hiking and whatever in small areas you got exposed. Okay, so epidemiological. So you should have an epidemiological indicator saying that you have. So you cannot say every fever incident that do a laptop. No, that history is very important. You understand? That history is very important. So if you have 15 points coming from here and you have 10 points coming from here, imagine, then only you can actually say it's 20, 25, because 25 plus is what you require. 25 plus is what you require to call it as leptospira. So when you're looking at this, because initially you're not going to have leptospira, PCR and all these things, you're going to have all these tests. You're going to have a patient that's coming to you and you have to decide whether I'm going to give this patient treatment for leptospirosis or not. Isn't it? The test all comes at a later date. So for that, you need to understand the clinical factors. You need to understand the epidemiology. So if you have a patient who comes to fever chills and no epidemiology, leptospirosis is not there in my mind. It's not there because it cannot have 25 points from here. Are you understanding? It cannot have 25 points from here. Clear? Understood this? Then comes your laboratory, which is 15 points, which are large points. Laboratory. In the laboratory, so that means you should have some of this to actually do a laboratory or a high clinical suspicion that the laboratory will come out to be positive. Okay. So here the test of choice again I said was microscopic representation, but because we are in our country, we don't have a MAT. The next test that you can do is something called as macroscopic slide agglutination testing. Macroscopic. This was microscopic. This is macroscopic slide agglutination testing. You understand? Macroscopic slide. This also is not available. This could be problem. We are not getting this. That's why we tend to do something called as ELISA. This is basically IgM for leptospira. But my problem with IgM leptospira is what? It has to come, it will take some time. It will take some time before IgM become positive. You won't develop an antibody immediately. To develop an antibody, it will take some 3-4 days, 4-5 days it will take. You understand? It will take time. You understand? Clear on this? And also we don't know whether that is been there some days ago and now you had a new infection. Okay. The other thing is if you have the antibody positivity, that means MAT you done starting, then you repeat it again and there is a seroconversion. Okay, it was initially positive, became negative. The seroconversion, antibody conversion occurs. That also you can diagnose. But what you can understand from this? This microscopic agglutination testing is not available. IgM leptospira may come positive at a later date. And seroconversion we don't do. We don't do it now and after he gets well. So it still comes to where clinical diagnosis. One test that you can do in such cases is usually leptospira PCR, which can be positive from day one. Unfortunately, it is a very expensive testing. Unfortunately, it is a very, very expensive testing. You understand? It is there, PCR is there, but it's a very expensive testing. Direct microscopy, what you were talking, is almost obsolete. Nobody does a direct microscopy. Culture not possible. It takes years, months for it to grow. So you understand? The usual thing that we do for bacteria is what? Culture. We do a culture. We get a culture. We get positivity saying that this is what it is, isn't it? You can't do any of those. You understand? So the combination of this plus this plus this. So if you see here, if I get a positivity with ELISA, it's say 10 points, or for PCR 15 points, whatever 15 points. If I have 15 per year, and from here any of these two, 100% leptospira. Sound matter? So you should know this. So whenever you are taking a history in the monsoon season, this has to be there as a very significant part of your history. You know, this has to be there. I'm surprised why you didn't take a history for the girl who came in intubated, ventilated.
Dirty water.
Where was the history in your charts? Where wading in rainwater? Where is that?
Contact with dirty water was there, sir.
So where is that in the charts?
There, sir.
No. Whoever called me, who called me? One of you called me, right? I'm asking, क्या है? नहीं कुछ नहीं वो fever chills के intubator के लिए क्या है? What am I going to understand from that? What can I understand from what you're saying? I am going to react on what you're going to tell me, no? Are you understanding? I'm going to react to what you're going to tell me. You understand? No mention about that. If you mention about the fact that she's waded in rainwater, and she has, you are not even asked these questions. Of any of these answers you are not given me. What is the fever? Is there chills? Was there headache? Was there a person of conjunctival suffusion? Was there neck stiffness? Was there meningism sign? Nothing was told to me. Are you understanding? Because you need to know these symptoms. It's important. It's important. If you know these symptoms, then only you will ask these questions. Otherwise, you will not ask these questions. You will just consider that I am ventilate करेंगे. You understand? That's why it's very important for you to have a clinical and everyone's diagnosis in leptospira. This part is later on. This is important. The clinical features are very, very important. And meningism, I said, is 10 points. Meningism is 10 points when it's got to leptospirosis. Clear? So what is the treatment of leptospirosis? Sachin? Doxycycline are mild, absolutely mild cases. तुमको BMC में मिलेगा doxycycline. It's the mild cases. Okay, it's mild cases. What is the treatment of choice? The treatment of choice is crystalline penicillin. The treatment of choice is actually CP, crystalline penicillin. That is the treatment of choice. Crystalline penicillin is the treatment of choice. The best drug to use in leptospirosis is crystalline penicillin. If you don't have CP, then the next drug is ceftriaxone. Then the next drug is ceftriaxone. Okay, it is not doxycycline as a drug of choice. You understand? It's only for the mild.
The mild, if you seem suspecting, we can start.
So normally doxycycline you what? Today you are waiting what to take a doxycycline. It's like a prophylaxis. You understand? Like for example, now if you go to the periphery, maybe BMC give to everyone.
गाइडलाइन आया सर
Family prophylaxis
Doxycycline.
देते हैं ना
Every day.
if the patient suffer that
So now in our city also, when there is a lot of rain happening, no, these people go to BMC, goes to those patients where there is rainwater accumulating, and they give doxy to everyone.
आया सर BMC का गाइडलाइन
क्या?
अभी एक 15 days पहले
क्या?
prophylaxis for leptospirosis 200 mg weekly for 4 weeks.
They'll continue like that. They'll give doxy to everyone.
200 mg once a week. ऐसे 4 to 6 weeks
So
continue
the
करो.
guideline says every day. The guideline actually will say the days you're waiting, take it on those days.
100 BD for a weight.
100 OD prophylaxis for the patient for a person who's waiting every day. मतलब 5 दिन से घूम रहा है तो 100 mg every day ले लो. ऐसा would be what something is there in the past. Okay, that's what we would recommend. Right, and that's why most of the patients who are also coming from abroad, they are on doxy. They are on doxy for this reason only, because they'll wait in a water which will basically be full of leptospira, which may cause this kind of an issue. Okay, so that's the treatment of leptospirosis. It's a simple treatment, but the patient gets very complicated because of various other manifestations or complications of lepto, because it's not treated early, which includes pulmonary hemorrhage, which includes hepatorenal syndrome, which includes severe jaundice encephalopathy, which includes bleeding manifestations. Classically, in leptospirosis, you will find the bilirubin to be high, whereas the SGOT-SGPT to be lower. Classically, what you will find in the LFT, you will find the SGOT-SGPT to be 80s, 90s, 100s, but the bilirubin will be 4, 5, 6. This is what you will see. You will see the opposite in hepatitis. In dengue, you will see the opposite. Okay, I'm just telling you how to differentiate the laboratories. Okay, so if you have leptospirosis, you will have bilirubin to be on the higher side, and you will have SGOT-SGPT to be on the lower side, 70s, 80s, something like that. But when you see malaria or dengue, you will have SGOT-SGPT to be 500 and thousands, and bilirubin to be 1 and 2. Okay, for the lady on top, it will be like that. It will be like that. It will not be the other way around.
Nice.
Right? When you look at typhoid, the laboratory will show you an eosinophil that is 0.
eosinopenia.
You will find eosinophilia is 0. Penia, 0. Eosinophil will be 0 in such cases. Okay, you will find eosinophil will be 0. So the laboratory, you look at it, you see eosinophil 0. Then you should start thinking whether I am dealing with typhoid. The rest of all these parasitic illnesses will actually cause eosinophil to be 2, 3, 5, 6, 7, 10 something. You understand? But salmonella will actually cause eosinophil to be usually 0. Okay.
Counts also not up there.
Yeah, so WBC counts are one of the indications of salmonella. Okay, the WBC counts with that W will be normally everyone. Let it be dengue, let it be malaria, let it be leptospirosis. You will not find the WBC count to go up. What you will find going up in the case of dengue is hematocrit. Okay, you will have the hematocrit to be high. So in the laboratory, when you look at hematocrit, you can say, okay, this is probably related to dengue fever. Platelets, there's another thing. You just don't look at platelets and say this is going to be malaria, dengue and lepto. It's either one of these, but leptospirosis will not cause the platelets to drop majorly. Dengue is the one that causes the platelets to drop majorly. Malaria also doesn't drop the platelets majorly. It's dengue is the one that drops the platelets majorly. Okay, whereas leptospirosis will not drop the platelet count as such majorly. It will come down, thrombocytopenia would be there, but thrombocyte will less than 1.5 lakhs. It's not 20,000 and 30,000 which you might see with dengue fever. Right? Malaria will come with hemoglobin on the lower side. Malaria will come with hemoglobin on the lower side. Till now we didn't talk about hemoglobin on the lower side. Anemia has got a very close association with malaria. Why anemia has got a close? Anybody? Anybody?
Yes, sir.
Why?
Hemolysis.
Cycle.
Why?
Intravascular hemolysis.
So if there is intravascular hemolysis, then all patients should have indirect hyperbilirubinemia. You don't see it. If there is intravascular hemolysis, what should happen? Indirect bilirubin should be
Yes.
released. You don't see that. There are multiple reasons for anemia and malaria. Multiple reasons. One of the reasons is once you get malaria, there is going to be immediate dyserythropoiesis. Immediately there is going to be dyserythropoiesis. Your bone marrow stops producing so much of hemoglobin. It almost stops producing. So 4-5 days after malaria, 7 days after malaria, you'll see the anemia being there because dyserythropoiesis is occurring. Okay. The second thing is there is some amount of hemolysis that is occurring, but not excessively. Why does hemolysis occur? Why does it occur? Is it bad, good? What is it? It is actually good, no. Because what is happening is in your life cycle of malaria, what's happening? The parasite is coming, attaching to your RBC, and then getting inside your RBC. That is why they call us parasitized RBC. That's why they call us parasitized RBC. And our body is so good that it recognizes those parasitized RBCs and goes and takes them out. And that's why your spleen increases. The spleen is overworking. Your spleen is overworking. So what happens is your RBCs are parasitized. And importantly, funnily, all those RBCs that are young are parasitized faster. Those RBCs that are young are parasitized fast, not the old ones. Old ones जो 110 दिन तक पहुंच गया है, वो उसको कुछ नहीं होता है. जो young रहता है, उसको parasitize कर देता है. So young RBCs become rigid. They are not deformable. Since they are not deformable, they don't go through everywhere causing rouleau formation. They create rouleau formation causing vasculitic insults. And at the same time, they are actually taken up by the spleen. So young RBCs are going down, that's why anemia is coming in. You understand? So there are multiple reasons why a person gets anemia in malaria. Okay, and you could attribute that to dyserythropoiesis. You could attribute that to take consumption by the splenomegaly, and you could attribute that to a little bit of intravascular hemolysis also. Okay, so in leptospira, when you look at this anemia, then you're looking at a very high disease called as Weil's disease, which is basically the icteric form of leptospirosis. In the icteric form of leptospirosis, you can have something like this. Okay, Weil's disease is called the icteric form of leptospirosis. There is an anicteric form and the icteric form. The icteric form is when jaundice comes in. So we call them as Weil's disease. Okay, whereas leptospirosis otherwise is normal. It's something you talk about fine, fever and chills. Fever. You understand? Huh? So you will see anemia in which disease now? Malaria. Right? Huh? Dengue. In dengue, what can you see? You can actually have cerebral malaria, you can have leptospira encephalopathy, and you can have dengue encephalopathy, malaria encephalopathy. All three can occur. You can have cerebral malaria, you can have leptospira causing leptospira-induced dysfunction in the brain, and you can have dengue causing dengue encephalopathy. Encephalitis. So there's two different things. What is encephalitis? What is encephalopathy?
I think inflammation of brainstem and personality changes.
But it's inflammation.
Encephalitis means the brain is insulted with a physical problem, which you can see on CT scan, but you can see on an MRI. That's why if you have a patient who comes in with altered mental status, why do I want to do the MRI? Herpes simplex encephalitis, HSV encephalitis. Herpes simplex encephalitis, I can pick up on a normal MRI by temporal lobe related having problems. Encephalitis changes in temporal lobe. You understand? Similarly, dengue per se, you have 4 serovers. Dengue 1, dengue 2, dengue 3, dengue 4. There are 4 serovers of dengue. There are 4 serovers of dengue. Right? 1, 2, 3, 4. Unfortunately, they are non-neurotropic. They are really not, they don't get into the brain. They are actually supposed to be non-neurotropic. Okay, they are non-neurotropic. Somehow, if what happens to dengue? They develop encephalopathy. Okay, they develop more encephalopathy. Very rarely they develop dengue encephalitis. Of course, we are in the era of mutations. We are seeing mutations. So very rarely you develop encephalitis. And for that, the classical description of encephalitis is an MRI that shows the thalamus to be hyperintense. The classical manifestation is bilateral thalami showing hyperintense shadow. So if you have a dengue fever, you do an MRI, it's normal. What do you call it as? With a patient of cerebral signs? Dengue, encephalopathy. You do an MRI, you see classically you shined hypertense thalamus, you call it as encephalitis. You understand? So that's the difference between dengue, encephalitis, and encephalopathy per se. Alright, so usually in dengue you don't see encephalitis. You normally see dengue encephalopathy. Okay, you understand what I'm saying? It's very different, okay? Very different. Both things are very different. Clear? Okay. So now the last patient that we have here is Gurbachan. Okay. So influenza H3N2 with superadded shock, admitted to some ICU, was put on ventilator, oxygenation is maintained. This is what normally happens in any nursing home. Every nursing home will have this situation. But then why do you think I am talking about this? Because this was a study that was done by India. Okay, multiple people, almost 3,000, 4,000 doctors were there in the study. 4,108 qualified physicians were there in this study. 366 sites published 2 years ago. Huge, all pulmonologists. I think almost every pulmonologist was participating in this study. All pulmonologists, and they looked at 4 seasons and what are the respiratory illnesses that are coming. Okay, and they found that in monsoon the respiratory illnesses go up. 29%, 30% monsoon illnesses. In monsoon, respiratory illness going up in monsoon. So when we talk of monsoon illnesses, no, this is none of that. There is one of that. That's why you see a spurt of H1N1, right? You are seeing viral illnesses, people having cough. Regularly you are seeing that because this is what you are seeing in the monsoon. So it's a part of your monsoon related illnesses, 30%. It's not there in the summer, it's not there, it's very lesser in the rest of the climates. It's more in the monsoon. I would have given to think that it is more in winter, but no, it's in monsoon. Monsoon you have more amount of illnesses, okay? So in this case, he will definitely have this, but you require to get the right tidal volume, right pressure, right energy, right fluid, right respiratory, right control pressure, right aerosol, right antibiotic. So too many things together. Too many things together if you want to treat this patient. You need too many things to treat this man. It's just too many things. So if I am having my uncle, my auntie in say a nursing home, that's not the place that I'm going to look at. Because this patient can die because you need the right things over here, because that is the only thing that is going to help. There is no drug and all. The drug only reduces viremia. It doesn't really cure anything. When you're giving Tamiflu, it doesn't cure anything. It reduces your viremic period. You understand? It's not curing the roaming out of the virus. You understand? It's just reducing your viremic period. That's all it's doing. It's not really removing anything. It's not the load. It is reducing the viremic period. The period in which you will be problematic. Okay. So he needs an ICU. That's why he needs something that will require a lot of things. You need to require B2B monitoring, cardiac output monitoring, blood transfusion services, talent, close quality monitoring, superior ventilation, bedside USG, so many things. So personally, I feel we cannot manage these patients in normal people. You cannot normal ICUs. It requires a very high-fi ICU. I think that's the reason that we lose a lot of patients in the periphery. And because the periphery will not have this kind of deaths we don't see in the metropolitan region per se. We see patients coming in quite late in the intensive care, and then by that time they are already very badly sick. For example, the lady that's intubated. For the lady that is intubated, she's been in another hospital for like 5 days, 4 days, 3 days or something. Another hospital. She should have been shifted a while ago. She should have come a while ago, isn't it? They have put her over there, kept her on NIV, did not ventilate, kept her that way. She worsened, RR was high. We understood now high RR, what can occur. She just went on into that circle of RR being high, being worse, then worse, and worse, and then she came to us. And she has a chance of dying. Isn't it? So that is why such patients, if you hear from somewhere that he's admitted into this hospital, no boss, you admit to some bigger hospital. You admit to some bigger hospital. Of course there is an expenditure, but that's what you need to do, because otherwise you are not probably giving the right service, is what I feel. As a doctor, you shouldn't advise. What they want to do is their lookout. Alright, any questions on tropical illnesses? Any